Hi everyone, and welcome back to Dr. Curnew's YouTube channel. Today the Breathing Club is here to talk about pulmonary hypertension and edema. We'll talk about each of these individually, talk about their symptoms and causes, along with some similarities and differences, and end with talking about some diagnosis and treatment options. But let's get started talking about what pulmonary hypertension is. Pulmonary hypertension is a condition in which the blood pressure in the arteries of the lungs become abnormally high. These arteries are normally responsible for carrying blood from the heart to the lungs to pick up oxygen to be distributed to the rest of the body. In pulmonary hypertension, these arteries become narrowed or stiff, increasing resistance to blood flow in these vessels. This means that the heart has to work much harder to pump blood through the lungs. This can weaken the heart over time and, of course, increase blood pressure. It is important to note that pulmonary hypertension isn't the same as just regular high blood pressure, where the arteries throughout the blood are affected. In pulmonary hypertension, the lungs and the right side of the heart are specifically targeted, making it a unique and serious condition.
Next up, let's take a look at pulmonary edema. Pulmonary edema is a condition in which there is a buildup or an excess amount of fluid in the air sacs within the lung. These areas are also referred to as the alveoli, which play an important role in the gas exchange process in respiration. Normally, the gas exchange process entails the diffusion or transport of carbon dioxide outside of the bloodstream, while oxygen diffuses into the bloodstream. This process allows us to breathe and transport oxygen to the different regions of our body with the circulatory system. However, in pulmonary edema, the excess fluid floods the alveoli, reducing the available surface area for gas exchange. It also thickens the barrier between the alveoli and the blood network, preventing oxygen diffusion into the blood. This, in turn, makes it difficult to breathe.
Finally, we will be discussing how pulmonary hypertension and edema are diagnosed and treated. First, we will be discussing diagnosis of hypertension. Even prior to diagnosis, regular screening is vital to detect for possible cases of hypertension. Blood pressure measurement is the gold standard for screening, which should be emphasized in patients with any of the following risk factors for hypertension. So diabetes, chronic kidney disease, low intake of fruits and vegetables, and a sedentary lifestyle. For reference here, I've included the Hypertension Canada algorithm for diagnosis. We see that a mean office blood pressure, or OBPM, of multiple readings above 180/110 is sufficient for a diagnosis of hypertension. But what I want to emphasize here is that in-office blood pressure measurements may not always be 100% indicative or accurate. Some patients may have white coat syndrome, where blood pressure monitoring is normal at home but high in the doctor's offices. Or the opposite can happen, where blood pressure readings appear normal at the office but are elevated outside of the office, which is known as masked hypertension. This is why out-of-office blood pressure measurements via ambulatory blood pressure measurement or at-home blood pressure monitoring may also be required. We see this in the case of diabetes, which is a risk factor for hypertension. So if we retake the diabetic patient's blood pressure and it falls above 130/80 on three different days, we do out-of-office measurements to rule out white coat hypertension. After patients have been diagnosed with hypertension, baseline measurements should be taken for cardiovascular risk factors, so diabetes, such as we discussed, hyperlipidemia and renal disease, as well as target organ damage. So that's when high blood pressure causes damage to organ groups, such as hypertensive retinopathy, as well as routine testing that would include urinalysis, blood chemistry, blood glucose levels, cholesterol levels, and an ECG electrocardiogram. First line or initial treatment includes both health behavior modifications and possible medication. Health behavior modifications consist of physical activity, so getting more active, improving your diet, reducing your weight, alcohol or smoking reduction or ideally cessation, and relaxation strategies. First-line medication includes diuretics, specifically thiazide or thiazide-like diuretics, for example, indapamide, and also includes ACE inhibitors, so angiotensin-converting enzyme inhibitors, such as perindopril, ARBs or angiotensin receptor blockers, such as candesartan, and beta blockers, such as bisoprolol. Now we're going to be moving on to diagnosis and treatment of edema. So diagnosis of edema is not as numerical as pulmonary hypertension, but rather it's based on physical examination. So if your healthcare provider can see a buildup of interstitial fluid, typically in the legs, feet, and/or ankles, they would suspect edema. Next, further investigations are conducted to determine the cause of edema. This begins with taking the patient's history. They would assess for the timing of the edema, whether it's unilateral or bilateral, so one or two legs, and the medication history, which allows us to assess for systemic diseases. So for example, if we're looking at acute versus chronic edema, if it's acute, so short-term spontaneous edema, this might be indicative of deep vein thrombosis or cellulitis, whereas chronic edema might be caused by chronic conditions such as congestive heart failure and hepatic disease. We also look at whether it's unilateral or bilateral. So if it's unilateral swelling, that might be resulting from deep vein thrombosis or venous insufficiency. If it's bilateral, that might suggest a systemic cause, such as congestive heart failure or hypertension. Further physical examination is also needed at this stage to probe for systemic causes of edema. We also need to evaluate the edema itself. For example, we need to look at whether there's pitting in the edema. So whether if an indentation that's put inside put at the area by the healthcare provider applying pressure would actually stay there, so it remains there. And if that's the case, that might be indicative of deep vein thrombosis or congestive heart failure. And finally, moving on to treatment, this is based on the cause of the edema. So for example, if it's caused by lymphedema, then physiotherapy might be used. On the other hand, if it's caused by deep vein thrombosis, then anticoagulation therapy might be used with heparin or warfarin.
If you would like to learn more about other heart or lung-related conditions, check out our video on cardiac asthma or our webinar on pulmonary fibrosis. We hope you learned something new from this video, and thanks so much for watching.